بسم الله الرحمن الرحيم. الحمد لله والصلاة والسلام على رسول الله وعلى آله وصحبه وسلم أجمعين. اللهم انفعني بما علمتني وعلمني بما ينفعني وزدني علما إنك العليم الحكيم. اللهم أخرجنا من ظلمات الوهم وأكرمنا بنور الفهم وافتح علينا بمعرفة العلم وسهل أخلاقنا بالحلم. اللهم آمين وأجمعين. اللهم ارزقني نعمة الإخلاص لوجهك الكريم بكل ما أقول وبكل ما أفعل. My topic today is about imaging of the approach to the posterior mediastinal mass. I will not discuss the differential diagnosis in detail. I will present some of the radiological signs that help you to determine that the lesion is in the posterior mediastinum. Okay, this is why it is not working. Okay. As you see here in this video clip, this is in the yellow line. It is the superior mediastinum. Okay. This is the superior mediastinum. In the brown, it is the anterior mediastinum, and in the green, it is middle mediastinum, and in the blue, it is posterior mediastinum. Today, we will discuss the imaging approach of the posterior mediastinal mass lesion. Okay, these are the blue. As we see here, this is the posterior mediastinum, and the posterior mediastinum, it is posterior to the trachea, and it is posterior to the pericardium. What is posterior to the trachea wall and posterior to the pericardium? It is a posterior mediastinum. And the contents of the posterior mediastinum: thoracic spine, paraspinal nervous system, paravertebral soft tissue, distal azygoes vein, hemiazygous venous system, and esophagus. What are the pathology? We will not discuss the pathology in details, but we will give some examples. The pathologies: malignancies, mesothelioma of the lung, neurogenic tumor, schwannoma, lymphoma, sarcoma, lymph nodes, aortic aneurysm, extramedullary hematopoiesis. Here, summary of the posterior mediastinum. As we said, it is posterior to the pericardium, and it is bounded by posterior chest wall. And it is contents: descending aorta, esophagus, vertebral bodies, nerves, lymph node, and connective tissue. What are the radiological signs we look for to determine the lesion? It is in the posterior mediastinum. We have some signs here, and we will discuss each one with some example. The first one, it is thickening and distortion or disruption of the paraspinal lines. This is here chest X-ray of female patient. As we see here, this is the right paraspinal line, and this is the left paraspinal line. And the left paraspinal line, it is medial to the paraaortic line. Paraspinal line, it is interfaces between the lungs and the paravertebral fat and soft tissue. It is vertical line parallel to the spine. Left, it is from the left one, it is from the aortic arch downward, and medial to the Paraaortic line. And the right one, it is in the right thoracic spine. The left stripe is more common seen than the right one because it is tangential with the aorta and X-ray interface. The right paraspinal line appears straight, vertical, extend from 8 vertebra to 12 thoracic vertebral level, and can be displaced laterally by osteophytes or by mediastinal fat or by abnormal masses like hematoma or mass lesion, extramedullary hematobiosis. And left paraspinal line, it is started from the, as we said, it is more seen than the right one, and it is tangential in contact of the left lung and the pleura, and it is seen extended from aortic arch to the diaphragm. As we see here, as in the first, this is in the chest X-ray, this is the right paraspinal line and extended from D8 to D12, and this is the left paraspinal line and extended, and it is medial to the paraortic line here, and extended from the aortic arch to the diaphragm. And the left one, it is more prominent than the right one. As we see here is another patient. We have some osteophytosis in this patient, and we see the paraspinal line on the right side, and it is outlined by green arrows, and this is the left paraspinal line by green arrowheads, and here we see the paraortic line on the dashed blue. And we see here in the corona reconstructed image, we see the left paraspinal line here, and this is the right paraspinal line. And on the axial cuts, and we see here, this is the aorta, and this is the paraspinal line on the left side, and paraspinal line on the right side. And this is the left side paraspinal line. Let us, this is another patient. We have paraspinal line on the right side as it is outlined by this diagram, and the left one, it is here, and it is, this is the paraortic line. Here, another axial cut CT scan, and we see the the right paraspinal line here, well defined, and the left paraspinal line also well defined. Here we see a patient with abnormal paraspinal line. Let us analyze the image. Here we see the right paraspinal line. It is okay, and it is in that area. It is started to be deviated laterally, as we see in this area, and also in the lower part of the left paraspinal line. It is okay here, and it is started to be deviated or laterally displaced. And here, the upper part of the left paraspinal line, it is well seen very nice, and we lost the definition of the left paraspinal line in that area. What is that? What we see here, this patient has trauma patient, and we see here, we see mass lesion in that area. That mass lesion in that area causing obliteration of the paraspinal line on the left side. And here, patient with, as I said, a patient with trauma, and we see here on the axial cuts, paravertebral hematoma on the both sides, displacing the paraspinal line. And in the coronal cuts, as we see here, this is the hematoma in this patient, displacing the paraspinal line. Let us see another example. Here, another chest X-ray front view, and we see the right paraspinal line. It is relatively thick in that area, and relatively thick in that area and outlined by the arrow. And also here, some displacement of the left paraspinal line. And here the cut at the level of the left side. And we see here, this is the patient has right paravertebral soft tissue. It is outlined by the arrow. And this patient has also a traumatic injury to the to the to his back, and we have paraspinal hematoma with bilateral pleural effusion. Another patient here, we have on the chest X-ray here. This is the right paraspinal line. It is okay. The left paraspinal line, it is nice, and then it is bulged and displaced laterally by soft tissue mass here in that area. And this, it is oval soft tissue mass, and we see here in this coronal image of the MRI, and this mass, this is the normal left paraspinal line, and this is the right paraspinal line. It is okay, and the mass, it is here, and this is representing paraspinal mass, and this is a patient with a neurogenic tumor. Here, this is another patient. We have chest X-ray of this patient, and we see here there is also bulging of the right paraspinal line here in that area and in that area, and also here this is the also bulging of the left paraspinal line and left paraspinal line here. It is looks like a fusiform mass lesion around the paravertebral area, and this patient has TB, and we have paraspinal abscess here, as we see here, by bilateral collection of the abscess on the paraspinal with bony destruction of the vertebra associated with left-sided pleural effusion. And also the abscess, paravertebral abscess, it is displacing the aorta. As you see here, this is how much the paraspinal line, it is displaced by this abscess formation. Another important sign for characterizing, for localizing the mass lesion in the posterior mediastinum, it is abnormal contour of the paraaortic line. And paraaortic line, it is interface between the descending aorta and the left lung, and it is in the posterior mediastinum. And normally it is a vertical line and parallel and generally external to the left paravertebral stripe, as we seen in the previous examples, normal and abnormal. And in the lower third, it may be overlapped with paravertebral stripe. As we see here in this example, this is the right paratracheal stripe here. This is normal, and this is the aortic knuckle, and this is the left paraaortic line. And here, as we see, it is overlapped in its lower part with the paraspinal line on the left side. So this is the aortic line. It is outlined by the black arrows. As we see here with the green line, green dashed line, this is the paravertebral line on the left side. Sorry, paravertebral line on the, or paraspinal line on the left side, and this is the this is the paraaortic line on this. It is outlined by blue arrows, and as we see here in this area. And also we see here, this is the descending aorta here, and the descending aorta here, and this is the para-aortic line outlining the descending aorta. And this is the right paravertebral line or paraspinal line, and this is the left paraspinal line or paravertebral line, as we see here and we see here. Abnormal appearance of paraaortic line can be due to either vascular causes or other mediastinal mass lesion, and can be displaced even in the elderly patient from the tortuosity of the aorta. Let us see some examples. Here, this is an elderly patient, and you see here, this is the paravertebral line on the left side, or paraspinal line on the left side, and you see here the paraaortic line, and it is displaced due to tortuous aorta. Here, another patient with aortic dissection, and we see aneurysmal dilatation of the aorta with tortuosity, and the paraaortic line, it is displaced laterally due to, as I said, it is due to aortic dissection. The third sign, we look to localize the mass. It is distortion of azygoesophageal recess. Azygoesophageal recess, it is interface between retrocardiac mediastinum, either esophagus anteriorly and azygous vein posteriorly, and the right lower lobe. As we see here, this is the patient with chest X-ray. We see vertical line here, vertical line coming from midline on the left side and going up to the at the level of the aortic arch. And this line, this is azygoesophageal recess, and it is any displacement of this line, it will indicate that mass it is in the posterior mediastinum. And we see here, this is another patient with chest X-ray with some tortuosity of the aorta. And here, this is the azygoesophageal recess. Here, and this can be seen as reverse C shape or reverse S shape. And it is seen in the coronal reconstruction here. And it is also seen in the axial cut here. And this area, it should be concave. Any convexity of this area, it is indicating that there is mass lesion pushing the azygoesophageal recess in that area. Okay, and this is the coronal reconstruction, and here this is the azygos and azygos vein, and this is the azygoesophageal recess. As we see here, it is posterior to the left atrium and anterior to the azygos vein. So distortion of the azygoesophageal recess, it is line, as we said, it is shallow reverse C shape or reverse S shape, and extended from the azygos vein to the diaphragm, as we see here, extended from the azygos vein. This is azygos vein to the diaphragm in this area. And any abnormality in the in that area will cause distortion of the azygoesophageal recesses, like lymphadenopathy for gut cyst, left arterial dilatation, esophageal disease, and even hiatus hernia. As we see here, any displacement of the left arteria or esophagus or hiatus hernia or lymphadenopathy will distort the azygoesophageal recesses, as we said. Here, patient with simple case, chest X-ray, and we see here large hiatus hernia and the lower part of azygoesophageal recess. It is displaced laterally and convex, and this is, we see also air fluid level in this patient, and this is the classic for hiatus hernia, and this is displaced of the lower part of the azygoesophageal recess, and this is the after the hiatus hernia or above the hiatus hernia. It is also little bit deviated to the left side. Here are some examples of the azygoesophageal recess. Here, as I said, this is the normal one in the axial cut, and this is the coronal reconstructed image. As we see here, it is concave, and slightly reverse its shape. As we see here in this patient, we have patient with esophageal tumor here, and instead of concavity here, it is convexity here, and we see the convexity, and it is displacing the azygoesophageal recess by this tumor. And this is another patient with varices, and we see also here convexity of the azygoesophageal recess, and we see the corona reconstruction, the convexity, and multiple variceal tortuosity seen in at the level of the diaphragm. And this is another example, patient with hiatus hernia, as we see here, and multiple lymph nodes. And we see here also the convexity of the azygoesophageal recess and with the hiatus hernia. And again, we stress this should be concave and with a slightly reversed S shape or C shape. And any convexity, whatever the cause, it is abnormal. The fourth sign, it is cervicothoracic sign. What is cervicothoracic sign? As you know, based on the fact that the anterior mediastinum, it is end at the level of the clavicle. إذا بتتذكروا فرجيناكم قبل يومين صورة anterior السايموما, it is ending at the level of the clavicle. This means that the mass, it is located in the anterior mediastinum. But if the mass, it is extended above the clavicle, as we see here, it is extended above the clavicle, so it is located in the posterior mediastinum. Sometimes it is located in the middle mediastinum, and sometimes it is located in the neck. Let us see one example of this. As we see here in this chest view, mass lesion on the left side, and this is the clavicle here, and the mass, it is extended above the posterior, above the clavicle, and this is mass located in the posterior mediastinum. And sorry. And we see the lateral X-ray of this patient, and this is located posteriorly mediastinal mass, and this patient has ganglioneuroma. Another example, we have large mass, and this is the clavicle here, and the mass, it is extended above the clavicle, pushing the trachea, and some calcification here, and the mass, it is located in the posterior mediastinum also. And the last sign of the localizing of the posterior mediastinal mass is thoraco-abdominal sign. Thoraco-abdominal sign, we see one example in the last case discussion, and the mass, any mass sharply marginated, seen through the diaphragm, above the diaphragm and below the diaphragm, so it is a mediastinal mass, and it is located in the posterior mediastinal mass. Okay, so any mass extend below the diaphragm and remains sharply must be located in the posterior compartment of the mediastinum. Okay, if it is terminate at the level of the diaphragm, it is located in anteriorly, like the clavicle. It is terminating, not crossing the clavicle, it is anteriorly located. If it is crossing the clavicle, it is posteriorly located. If the mass, it is seen above and below diaphragm and sharply marginated, so it is located posteriorly in the mediastinum, and it is not in the lung, it is in the mediastinum. As we see here, this child has large mass seen above the diaphragm, sharply marginated, and sharply marginated below the diaphragm, so that mass, it is located in the posterior mediastinum. And this is the lateral chest X-ray, and we see that mass, it is located in the posterior mediastinum, and this is the CT scan of this patient, and the mass, it is in the posterior mediastinum, and this mass, it is neuroblastoma. سبحانك اللهم وبحمدك أشهد أن لا إله إلا أنت أستغفرك وأتوب إليك. Any question? This is our end of our talk, and any question? Any question?
أستاذ ممكن سؤال؟
تفضلي.
أكو يعني one of the cases that represent اللي posterior mediastinal mass on chest X-ray. أي مثلا إذا انسألنا بالامتحان يعني شلون يعني discussion to differentiate this mass if it is intrapulmonary، ما أعتقد كانت الأنجل واضحة.
شوفي أي mass in the lung mass, pulmonary mass, it has multiple, it is أول شيء, it will not cross the midline. This is one. Posterior,
if it is large,
if it is large, even that, it is not to cross the midline. وهي واحد. اثنين, it is surrounded by air. Usually it is surrounded by air. It is okay. ثلاثة, إذا بتتذكروا حكينا في incomplete border sign.
Border sign, yes.
Yeah,
I remember.
Incomplete border sign, that mass indicate it is not pulmonary. It is outside the pulmonary. Other one, acute angle of the pulmonary mass and obtuse angle of the mediastinal mass. Okay? Acute angle of the pulmonary mass and obtuse angle of the posterior mediastinal, mediastinal mass. Okay?
Okay.
These are the differential.
Okay. Thank you.
Okay. Any other question?
ممكن سؤال استاذ لو سمحت؟
تفضل.
استاذ هل لو سمحت هل ممكن تمييز بين frontal chest X-ray between the morgagni herniation والhiatus herniation إذا ما في air fluid level بالريتروكارديا، هل ممكن نميز بالفرونتال؟ في شيء ساينس نعتمد عليها ولا خلاص نقول مثلا الموست كومن hiatus hernia وخلاص؟
It is hiatus hernia. It is اللوكيشن احنا حكينا هذيك المره اذا بتتذكر bodily hernia. It is usually seen on the children او in the neonates اكثر من الchildren. مظبوط ولا لا؟
نعم.
اوكي، هاي واحد. اثنين انه انت طبعا احنا هسه مع السي تي سكان انا حكيت لك المره السابقه we see a lot of bodily hernia even without history of trauma, and these sometimes it is difficult to diagnose what is this because most of it is fat density. Okay.
Okay. تسلمي.
Any other question?
Thank you دكتور. تسلم.
اوكي ان شاء الله. شكرا لكم جميعا ونشوفكم ان شاء الله بالمره السابقه يا الله. يلا السلام عليكم في امان الله.
شكرا جزيلا استاذ.
شكرا جزيلا.
تصبح على خير.
شكرا جزيلا.
مع السلامه.
شكرا جزيلا. تصبح على خير. مع السلامه.
يوم الأحد يشوفنا؟
والله ما بعرف، يوم الأحد أو الاثنين مش عارف، حسب التساهيل إن شاء الله.
شكرا دكتور.
يلا مع السلامة.
مع السلامة.
مع السلامة.